This session focuses on viral infections of the upper respiratory tract. In our previous session, we covered bacterial causes of upper respiratory infections. Today, we'll focus on the major viral pathogens that affect the upper respiratory tract. This comprehensive table summarizes the key characteristics of the 5 major viruses causing upper respiratory tract infections. Starting with human rhinovirus, the main disease it causes is rhinitis, or the common cold. Remarkably, there are more than 120 different serotypes of rhinovirus, which is why we can get multiple colds throughout our lives. Immunity to one serotype doesn't protect against others. Human adenovirus causes rhinitis, pharyngitis, and tonsillitis. There are 57 known serotypes, with types 1, 2, 3, 5, and 7 being most commonly associated with URT infections. Human parainfluenza virus causes laryngitis, including croup in children. It belongs to the Paramyxoviridae family. Unlike the previous two, it's enveloped, having a lipid membrane surrounding the viral capsid. Coronavirus causes rhinitis and was a relatively obscure pathogen until recent years. 2 main types cause common colds, HCOV229E and HCOVOC43. Finally, Epstein-Barr virus causes pharyngitis and tonsillitis, specifically infectious mononucleosis. Unlike the others, it has no multiple serotypes, as there's essentially one strain that affects humans. All these viruses share common modes of transmission: through touching or shaking hands of infected persons, through the air by coughing and sneezing, and by touching contaminated objects or surfaces, then touching your mouth, nose, or eyes. Let's apply our knowledge to a clinical case. A 32-year-old otherwise healthy individual presents with classic symptoms of a common cold. The patient has a runny nose, sneezing, and nasal congestion. These symptoms started a few days ago and are progressively worsening. Importantly, the patient denies having any fever or sore throat. This is a key clinical feature that helps distinguish a simple common cold from more serious infections like influenza or streptococcal pharyngitis, which typically present with fever. On physical examination, there is clear rhinorrhea, which means clear nasal discharge. The color of nasal discharge can be clinically informative. Clear discharge suggests viral infection, while yellow or green discharge might suggest secondary bacterial infection, though this isn't always reliable. The nasal turbinates, which are bony structures inside the nose covered with mucosa that warm and humidify inhaled air, appear pale and swollen. This swelling is due to inflammation and increased vascular permeability caused by the viral infection and the body's immune response. This clinical presentation is classic for viral rhinitis, or the common cold. The common cold is one of the most frequent illnesses affecting humans, with adults averaging 2 to 3 colds per year and children having even more, sometimes 6 to 8 per year. While it's generally a mild, self-limiting illness, it has enormous economic impact due to lost work and school days. Rhinovirus is the most common cause, responsible for about 30 to 50% of all common colds. This is followed by parainfluenza viruses, which cause about 10 to 15% of colds, particularly in children. Coronaviruses account for about 10 to 15% of colds, typically during winter months. Adenovirus can also cause rhinitis, though it more commonly causes pharyngitis. It's crucial to emphasize that rhinitis is predominantly viral in origin. Bacterial causes are rare. This is important because it means antibiotics, which only work against bacteria, are not indicated for treating the common cold. The widespread misuse of antibiotics for viral upper respiratory infections contributes to antibiotic resistance, a major global health problem. Rhinovirus is a small virus. Its genome consists of single-stranded RNA with positive polarity. Importantly, it has no envelope, meaning it lacks the lipid membrane that surrounds some other viruses. This makes it more stable in the environment and resistant to drying, which facilitates transmission through contaminated surfaces. The mechanism of cellular entry is well understood. The virus has glycoproteins on its surface that bind to ICAM, which stands for intercellular adhesion molecule. ICAM is a protein normally expressed on the surface of respiratory epithelial cells, where it plays a role in cell-to-cell adhesion and immune responses. Rhinovirus has evolved to exploit this molecule as a receptor for entering cells. For laboratory purposes, rhinovirus can be isolated and grown in cultures of human diploid fibroblasts. These are normal human cells that can be cultured in the laboratory. The virus causes characteristic changes in these cells, called cytopathic effects, which can be observed under the microscope. This diagram illustrates the step-by-step pathogenesis of how rhinovirus causes the common cold. Rhinovirus is transmitted primarily through direct contact with contaminated hands or surfaces, and less commonly through inhalation of aerosol droplets from coughs and sneezes. When a person touches a contaminated surface and then touches their nose or eyes, the virus is introduced to the nasal mucosa. Once on the nasal mucosa, The virus must attach to epithelial cells using its surface glycoproteins to bind to ICAM1 receptors on the surface of nasal epithelial cells. The viral multiplication causes the cell lysis. Most symptoms of the common cold are not from direct viral damage, but from the immune response. The infection triggers release of inflammatory mediators that cause vasodilation, increased vascular permeability leading to fluid leakage and swelling, stimulation of mucus-secreting glands leading to rhinorrhea, and stimulation of nerve endings causing the sensation of nasal irritation and triggering the sneeze reflex. Interestingly, rhinovirus typically causes minimal tissue damage and doesn't deeply invade tissues. The infection remains superficial, limited to the epithelial surface, which explains why the common cold is generally mild and self-limiting. Laboratory diagnosis of the common cold is rarely performed in clinical practice because it's usually a mild, self-limiting illness that doesn't require specific treatment. For specimen collection, nasal and throat swabs are appropriate for adults. The swab should be inserted into the nostril and rotated to collect epithelial cells and secretions. For culture, rhinoviruses can be grown in human diploid fibroblast cells and observed microscopically for cytopathic effects or CPE. Serological methods, which detect antibodies in the patient's blood, cannot be used for rhinovirus diagnosis. Why? Because of the multiplicity of serotypes. With approximately 150 different serotypes, it would be impractical to test for antibodies against all of them. Additionally, by the time antibodies develop, the patient has usually already recovered. It's important to emphasize that for routine clinical cases of the common cold, no testing is necessary. The diagnosis is clinical, based on symptoms and physical examination. Management of the common cold focuses on symptomatic relief and prevention of transmission, as there's no specific antiviral treatment available. Decongestants, either oral or nasal sprays, help reduce nasal congestion by causing vasoconstriction in the nasal mucosa, reducing swelling. However, nasal decongestant sprays shouldn't be used for more than 3 to 5 days to avoid rebound congestion. Prevention strategies are important for reducing transmission. Good hand washing is the single most effective preventative measure. Alcohol-based hand sanitizers are also effective. Now let's transition to discussing pharyngitis or sore throat caused by viruses. As we learned in our previous session, pharyngitis can be caused by both viruses and bacteria, and distinguishing between them is clinically important. The main viral causes of pharyngitis include several important pathogens. Adenovirus is one of the most common viral causes and will be our focus today. Coxsackie virus causes a specific type of pharyngitis called herpingina, characterized by small vesicles and ulcers in the throat. Parainfluenza viruses and influenza viruses can cause pharyngitis as part of a more generalized respiratory infection. Most importantly for today's discussion, Epstein-Barr virus causes infectious mononucleosis, which presents with severe pharyngitis as a prominent feature. It's important to remember the bacterial causes as well for comparison. Streptococcus pyogenes, also called Group A Streptococcus or GAS, is the most important bacterial cause, causing strep throat. Corynebacterium diphtheriae causes diphtheria, now rare due to vaccination, but still important to recognize. Distinguishing viral from bacterial pharyngitis has important therapeutic implications. Viral pharyngitis doesn't require antibiotics and is managed with symptomatic treatment. Bacterial pharyngitis, particularly strep throat, requires antibiotic treatment to prevent complications like rheumatic fever and post-streptococcal glomerulonephritis. Clinical features can help distinguish the two. Viral pharyngitis typically has a more gradual onset, is often associated with other symptoms like cough, runny nose, and conjunctivitis, and usually doesn't cause high fever or exudates on the tonsils, though adenovirus and EBV can cause exudates. Bacterial pharyngitis, particularly strep throat, typically has sudden onset, high fever, prominent exudates on tonsils, absence of cough, and tender cervical lymph nodes. However, clinical features alone aren't always reliable, which is why laboratory testing is often needed for definitive diagnosis. Adenovirus is a relatively large DNA virus compared to rhinovirus, making it one of the few DNA viruses that commonly infect the respiratory tract. Most respiratory viruses are RNA viruses. The structure of adenovirus is complex and elegant. It has an icosahedral capsid. Hexane is the most abundant antigen and is what the immune system primarily recognizes. The penton are crucial for viral attachment to host cells, and they are toxic, causing cell rounding and detachment, even without complete viral replication, contributing to cell damage. An important characteristic is that adenovirus does not spread beyond regional lymph nodes. The infection typically remains localized to the respiratory tract and draining lymph nodes, which explains the predominantly local symptoms. Some adenovirus infections persist as latent infections in tonsils and adenoids. There are about 51 antigenic types of adenovirus, classified based on their hexane and fiber antigens. Adenovirus is spread through several routes. Aerosol can be inhaled by others. Close contact. such as kissing or sharing utensils, as well as fecal-oral route, because the virus can be shed in stool for weeks after infection, and it's relatively stable in the environment. Once acquired, adenovirus infects and replicates in mucoepithelial cells lining the oral pharynx, as well as other parts of the respiratory tract. The clinical disease is determined largely by the serotype involved. Upper respiratory tract infections are mostly caused by adenovirus types 3, 4, and 7. Different serotypes have tropism for different tissues, with some preferring respiratory epithelium, others preferring conjunctival epithelium causing conjunctivitis, and others causing gastrointestinal symptoms. An important feature of adenovirus is that it can become latent and persist in adenoids and tonsils. Even after the acute infection resolves, viral DNA can remain in these lymphoid tissues. While this latency is usually asymptomatic, the virus may occasionally reactivate, and infected individuals can potentially shed virus intermittently. Let's examine a case of kissing disease, also called infectious mononucleosis, one of the most distinctive viral upper respiratory infections. A 17-year-old female presents with sore throat and fever that have persisted for 1 week. This duration is important. Strep throat typically responds quickly to treatment, while infectious mononucleosis symptoms can persist for weeks. A striking feature is extreme fatigue. She has spent most of the last 3 days in bed due to exhaustion. This profound fatigue is characteristic of infectious mononucleosis and can persist for weeks or even months, long after other symptoms resolve. It's one of the reasons infectious mononucleosis is sometimes called the kissing disease among teenagers and young adults, as it can significantly impact daily activities. She denies any ill contacts, which is common because the incubation period for infectious mononucleosis is long, about 4 to 6 weeks, so patients often don't recall exposure to infected individuals. On examination, her temperature is 38.5 degrees Celsius, indicating significant fever. Examination of her pharynx shows tonsils that are markedly enlarged, erythematous meaning very red, and covered with white exudates. This presentation can be mistaken for streptococcal pharyngitis, which is why it's called the great imitator. She has prominent cervical adenopathy, which is mildly tender. In infectious mononucleosis, lymphadenopathy is often generalized, affecting multiple lymph node groups, not just cervical nodes. The nodes are typically moderately enlarged and may be slightly tender, though they're not as acutely tender as in bacterial infections. A rapid streptococcal antigen test is negative, which helps rule out strep throat. This is an important diagnostic step when a patient presents with pharyngitis and exudates. The key diagnostic finding is that peripheral blood shows the presence of atypical lymphocytes. These are activated T lymphocytes with unusual morphology, appearing larger with abundant cytoplasm and irregular nuclei. The presence of more than 10% atypical lymphocytes in the blood is highly suggestive of infectious mononucleosis. This clinical picture is classic for Epstein-Barr virus infectious mononucleosis. Epstein-Barr virus is one of the herpes virus family member. It's a DNA with an envelope studded with glycoproteins. These glycoproteins are important for attachment to host cells and are also targets for the immune response and for diagnostic tests. A critical feature of EBV, like all herpes viruses, is its ability to remain latent in lymphocytes. After primary infection, the virus establishes lifelong latency in B lymphocytes. Periodically, the virus may reactivate and be shed in saliva, which is why EBV can be transmitted even by individuals who had infectious mononucleosis years ago. The disease caused by EBV is infectious mononucleosis, also known as glandular fever. The term mononucleosis refers to the increase in mononuclear cells, specifically lymphocytes and monocytes, in the blood. The term infectious distinguishes it from other causes of an abnormal lymphocyte count. EBV is also associated with several cancers, including Burkitt's lymphoma, nasopharyngeal carcinoma, and post-transplant lymphoproliferative disorder, though these are beyond the scope of our discussion on upper respiratory infections. This graph shows typical pattern of antibody formation to Epstein-Barr virus-specific antigens after a primary infection. Let's examine each antibody type. First, VCA-IgM antibodies appear early. VCA stands for viral capsid antigen, which are proteins in the virus's protein coat. IgM antibodies are the first type of antibody produced during any primary infection. VCA-IgG antibodies also appear early, around the same time as symptoms begin. VCA-IgG levels rise during acute infection, plateau, and then remain detectable lifelong. The presence of VCA-IgG without IgM indicates past infection and immunity. EA antibodies, where EA stands for early antigen, appear during acute infection. Early antigens are viral proteins produced during the early phase of viral replication. Anti-A antibodies typically appear a few weeks into the illness, peak, and then decline over several months. High levels of anti-EA suggest acute infection or sometimes reactivation. eBNA antibodies, where eBNA stands for Epstein-Barr nuclear antigen, appear late, typically not until 2 to 4 months after the onset of illness. Anti-eBNA antibodies develop slowly but persist for life. The presence of anti-eBNA antibodies indicates past infection. The absence of anti-eBNA in the presence of VCA-IgM and VCA-IgG indicates acute infection. This pattern allows us to determine whether a patient has acute infection, recent infection, past infection, or has never been infected based on which antibodies are present. For specimen collection, nasopharyngeal aspirates and throat swabs are appropriate specimens. The swab should sample the posterior pharynx and both tonsils to collect adequate material. For culture of adenovirus, isolation can be performed in primary human embryonic kidney cells. However, culture takes several days to weeks and is not commonly performed for routine diagnosis. Rapid methods have largely replaced culture for adenovirus detection. Immunoassays, including fluorescent antibody tests and ELISA, can directly detect adenoviral antigens in respiratory specimens within hours. For infectious mononucleosis, the monospot test is a classic rapid screening test. This test detects heterophile antibodies, which are antibodies that agglutinate sheep or horse red blood cells. These antibodies are produced in response to EBV infection, but don't actually bind to EBV antigens. They're a non-specific response. The monospot test is quick, inexpensive, and reasonably sensitive in adults, though it can be falsely negative early in infection and is less sensitive in young children. For more specific EBV diagnosis, EBV antibody testing can be performed using immunoblot assays or indirect immunofluorescence tests using EBV-positive lymphoid cells. These tests detect specific antibodies to VCA, EA, and eBNA as we discussed, allowing determination of whether infection is acute, recent, or past. Serological methods for adenovirus include hemagglutination inhibition tests and neutralization tests. These are specific and sensitive but require paired acute and convalescent serum samples collected weeks apart, so they're mainly used for epidemiological studies rather than acute diagnosis. Molecular methods have become increasingly important. Adenoviral genomic DNA can be detected by polymerase chain reaction or PCR. This is rapid, highly sensitive, and can be performed on various specimens. Multiplex PCR is particularly valuable, as it can simultaneously test for multiple pathogens in a single reaction. A single specimen can be tested for adenovirus, EBV, rhinovirus, influenza, RSV, and many other respiratory pathogens all at once, providing comprehensive diagnosis.